Good morning and welcome to the Palliative Care Friday Chalk Talks. Our topic today is on the hyperalgesic and the neurotoxic effects of opiates. Our guest speaker today is the wonderful Dr. Andrea Cordero Reyes. Andrea is originally from Ecuador, and she is currently in her 5th month of her hospice and palliative care fellowship at OSF Healthcare, University of Illinois, where she is accompanied by her 12-year-old dog, Oreo. And prior to that, she was a hospitalist at Presbyterian Rust Medical Center in New Mexico. Our format for today is going to be 2 parts. We have a short presentation, and then we'll have some time at the end for audience to ask questions. So with that, welcome, Andrea, and I will hand the mic over to you.
Thank you, Martin. Thank you for giving me the chance to present today. So it's a very exciting day. And as you mentioned, I'm going to be talking about opioid-induced hyperalgesia. I think that this is an under-recognized condition, and I think it's worth touching on it so that we all have it in our minds when we're seeing patients, when we're treating, whether it's in an acute setting or in a chronic setting. And to start, we can discuss a little bit about the historical perspective. There is some data starting in the late 800s where essays by certain scientists were being published, and they would relay symptoms related to the use of morphine and increased pain. They would say, I don't know if the worst evil is the treatment or the ailment, because they were starting to notice that once they started treating pain in certain patients, these pain syndromes would actually get worse. And obviously at that time point, they couldn't understand why was this happening or have an explanation for it. Until later in the 1970s, many studies started to be published, mostly in basic science with animals. And they would show that the administration of opioids would paradoxically increase the sensitivity to pain and worsen symptoms. They would do different ways of testing pain that we're going to touch on later on this presentation. And this kind of got into the clinical community, and they wanted to kind of start testing this in humans. Obviously, we always talk about ethics and how we can do this testing without harming patients. So the initial tests and studies that were done were mostly in the setting of acute post-operative pain patients, where they were able to see that if they were giving the patients high doses of opioids versus lower doses, these patients would become more hyperalgesic. They also did some studies in patients who had a history of opioid addiction, who were on chronic methadone therapy, and they found that those patients, compared to healthy volunteers who had no history of opioid use, they would have a higher threshold for hyperalgesia, a lower threshold for pain syndromes. And there are also some small studies on healthy volunteers, but in research settings, and some case reports in mostly shown in cancer patients, where they escalate doses fairly quickly and very high doses, and they had noticed that patients described the symptoms of hyperalgesia, allodynia, and whenever they treated it by either decreasing the dose of the opioid or introducing another opioid that is less OIH or opioid or hyperalgesic inducing, the patients would actually do better. So that's most of the data that we currently have. There's no clear-cut studies saying this exists or this doesn't exist, but I think there is already enough information that it merits us knowing that hyperalgesia is an important clinical scenario in certain patients. So how do we describe opioid-induced hyperalgesia? Well, the actual definition is a state of nociceptive sensitization caused by the use of opioids. And sometimes it can be a little bit difficult to differentiate hyperalgesia versus tolerance. It works in different pathways. Tolerance will work in the anti-nociceptive pathways, and it's a desensitization, whereas, as I say, in hyperalgesia, it affects the nociceptive, pro-nociceptive pathways. At the end of the day, the result is the same, right? The patient has increased pain, and the way you treat it, we're going to talk about it, it is different. So ideally, you want to be able to tell the difference between tolerance and hyperalgesia, because you'll treat it in a different way. I think it is worth touching a little bit on the mechanisms and the pathophysiology of this. And I know this made me bring out my physiology book from medical school out. And obviously, the basic concept of pain pathways, it's important because we're going to see that the theories or the hypothesis as to why hyperalgesia develops happens in different areas of these pain pathways, as you can see in this graph. So recalling how the pain pathway starts, you get a noxious stimuli, as we can see in this picture, and then we have nociceptor endings that get activated. A signal transduction happens, usually through primary afferent fibers of the neurons. This can be A delta, which are the small myelinated fibers, or C, that are the even smaller unmyelinated fibers. They will travel to the dorsal root ganglion, and then from the dorsal root ganglion, the signaling goes to the dorsal horn. This is usually the first synapsis or signal transduction happens. And then there is a crossover in the spinal cord at the same level, so that the signal travels through usually the spinothalamic tract to the brain through these different nuclei. And these nuclei are also important because these are part of that hypothesis that I was talking about, to the thalamus, the somatosensory cortex, and then that tells the brain something bad is happening, and then the brain in itself releases neurotransmitters, etc., so that there is a descending pathway and a descending response to this pain signal. That's sort of the basic of how the pain mechanism develops. And I apologize. And at the synaptic level, the normal non-pathologic effect of opioids is that opioids will bind mu receptors in the presynaptic neuron, right? And once they bind mu receptors in the presynaptic neuron, they cause calcium channels to close. And then this stops the release of glutamate in the synapses, which in turn also causes the increased release of potassium and decreased release of sodium, and that causes hyperpolarization of the postsynaptic neuron. Hyperpolarization of the postsynaptic neuron means that the action potential doesn't translate, and the pain signal gets blocked, meaning we no longer feel pain. This is in a physiologic state when patients are being given opioids. But one of the theories of opioid-induced hyperalgesia is that this becomes a pathologic response, and the patient keeps getting an opioid. Obviously, the most studied one is morphine, and the opposite effect happens, meaning, I'm sorry about the graph, it's a little busy, but it shows that there is large amounts of glutamate being released into the synapses, and that actually causes activation of NMDA receptors. And the activation of NMDA receptors will activate the postsynaptic neuron and polarize it, which in turn will cause increased pain signaling and release of pro-inflammatory cytokines, amongst many other things, inducing of apoptotic cell death and neurotoxicity, and obviously that late effect is increased pain. There have been studies using this NMDA receptor antagonist MK801, which has been shown that when they give this receptor antagonist, they block this hyperalgesic response and the patient no longer has pain. And other of the receptors that have been measured is the peptide calcitonin gene-related peptide and substance P in the dorsal root ganglia, and that also continues to stimulate this pathologic pathway of induced pain. Another theory is that of spinal dynorphins. These are endogenous opioids that our body produces, such as enkephalines, etc. It has been shown by certain studies that the overproduction of these spinal dynorphins from pain signals actually causes increased pain. And this has been tested specifically in patients who receive continuous doses of infusions of morphine, or in patients who have chronic pain. They have been able to measure the amount of these spinal dynorphins, and they're usually very elevated. And peptides such as CCK will stimulate also the production of spinal dynorphin and activate the spinal pathways. So the same story sort of in this case, either with endogenous opioids or with using morphine or other exogenous opioids. This stimulates the same pathways that cause hyperalgesia. And as we were talking before in the first picture, these nuclei that are very important in the medulla, such as the rostral ventral medial nuclei or the periaqueductal gray matter, these ones get significantly activated during hyperalgesia, and their overactivation causes increased transduction of pain signaling at the end of the day, increased pain or hyperalgesia. It is thought that there are also some genetic influences, and this is mostly being studied with the COMT gene, which is producing the enzyme catechol-methyltransferase, which we know degrades catecholamines. We've seen that there are 3 possible genetic genotypes or polymorphisms, and that in one of the polymorphisms, there is a substitution of valine for methionine, which we see that in those patients that have the valine substitution, the breakdown of dopamine or noradrenaline tends to be sometimes 4 times higher, which in itself means that it causes different synaptic levels of the neurotransmitters, and that causes activation or deactivation of the pain pathways. This has also been studied because it's been shown that those changes and those polymorphisms make people more sensitive to bipolar, anxiety syndromes, neuropsychiatric illnesses, but also more sensitive to pain. And the last pathway, which again follows all of these things that I was saying before, is that they have seen that there is decreased reuptake of neurotransmitters from primary afferent fibers. And then at the same time, the spinal neurons are very responsive to nociceptive neurotransmitters such as substance P and glutamate, as I was mentioning. So in conclusion, sort of all the pathways that we see from the primary figure that we looked at are overstimulated. And that overstimulation at the end causes hyperalgesia, and we'll see the symptoms of this. So how do we diagnose and manage hyperalgesia? And we'll see that this is not a one-size-fits-all kind of treatment, but it's always patient dependent. And we'll go through these 3 possibilities. We'll talk about the symptoms, we'll talk about what possible clinical tests can be done, and how we're going to treat it. The symptoms are usually, you will see a patient either in the acute phase or in the chronic phase who overall their pain was controlled, but suddenly their pain starts to worsen over time, even though you're increasing the doses of opioids. The other important symptom is that usually the original area of pain will become more diffuse and generalized. You'll have a patient who will always tell you, I have localized back pain to L2 level and radicular symptoms, for example. At that point, they will tell you, you know what, my pain is everywhere, my whole body aches, they will no longer be able to pinpoint where the pain is coming from. Allodynia is a very specific symptom of OIH, and it's usually pain due to non-painful stimuli, such as light touch. You'll be able to test it in a patient. And they will always have other accompanying symptoms. They will have increased anxiety at the same time, insomnia, they can have myoclonus. Obviously, the best way to see that this is truly OIH is that the symptoms will get better after the reduction of the opioid dose. And I'm not sure whether this is because morphine has been the most studied or because of its metabolites, but it's the most common opioid to cause hyperalgesia. These are clinical tests that are obviously not readily available everywhere, but it's worth knowing that they exist, and certain pain clinics do have them available. One thing that you would want to do is a thorough neurologic exam. You want to test for areas of hyperalgesia, dysesthesias, or allodynia. There are certain nociceptive tests to heat, certain mechanical tests. The two most commonly known and used are, one is the temporal summation with von Frey hairs, and these are thin hair looking probes which you continue to probe the patient in specific areas of the body, and usually their pain threshold will be lower than a normal control subject. The same thing with the algometer suppression test. This is a little device that has a probe that creates pressure in a specific area of the body, and it has an ascending pressure that is at a constant rate, and the patient will tell you when they develop pain. Again, the same story, the threshold will be much lower compared to healthy control subjects. Ideally, you could and will be able to diagnose hyperalgesia just by symptoms and the clinical presentation. What is thought to modulate opioid-induced hyperalgesia? Based off the graph of the potential mechanisms, it's known that there's overactivation of NMDA receptors by glutamate. So the thought process is that if you were to give these patients NMDA receptor antagonists, you could modulate their response. So those more well-known and studied are ketamine, methadone. There was a study describing dextromethorphan where they did give patients morphine versus Morphidex, which is a combination of morphine and dextromethorphan. And they actually found no significant difference, but they did see that there was improved analgesia by using Morphidex. Other medications that have been tested in a clinical setting are COX-2 inhibitors. These ones are modulating the pathway because they can also modulate NMDA receptors, as well as they inhibit prostaglandin release, and prostaglandins are also elevated in these patients. Another one that has been tested is propofol, and it works mostly through the interaction with GABA receptors at the supraspinal level, and then also alpha-2 receptor agonists such as clonidine or dexmedetomidine, which have been shown to improve the hyperalgesic response. So how do we treat it? There are certain treatment strategies that we can use, and as I said before, these are all patient dependent, and it all depends on which setting you're on, if the pain is acute, if the pain is chronic, the relationship that the provider has with the patient, and how much the patient is willing to try one of these. The first one is obviously reducing the doses of the opioids that you're using. That can sometimes be a lengthy process that can sometimes fail. So it's important to have this conversation with the patient and explain them the reasoning behind you wanting to reduce the dose of the opioid. And in the long term, the patient will notice that the pain goes away once you reduce the dose. Another option is doing opioid rotation. While you reduce somewhat the dose of the opioid that you're getting, you can put them on another opioid that is less OIH inducing. As I was saying, morphine is the most commonly known to induce more hyperalgesia. Or you can always try other opioids that have these properties, as I was saying, that can mitigate OIH, such as methadone, being an NMDA receptor and having NMDA receptor antagonist effects, as well as buprenorphine. Buprenorphine is being used more and more nowadays due to its effects of being a partial agonist and then an antagonist, as well as having effects in NMDA receptors. And the other option is having a multimodal approach in which you can add other medications. We know patients who have neuropathic pain could benefit from gabapentin, other medications. You can add COX-2 inhibitors if the patient has no contraindications for these. And you can use local therapies such as capsaicin cream, lidocaine patches, depending on when the pain is, using interventional pain as a tool, nerve blocks and so forth. And one that is very important is behavioral therapy. It's very important to introduce behavioral therapy early on in the course of these patients because these pain syndromes tend to be very difficult to treat. With that, I conclude this presentation, and I think the biggest take-home message is that whenever you run into a patient who's having trouble tolerating opioids, always try to keep in mind that hyperalgesia can be a clinical syndrome that the patient is suffering from. And once you recognize it, you'll be able to treat it.
Wonderful, thank you. There are a couple of questions that have popped up in the chat. What I'll do is I want to add a comment, ask you a question, and then we'll see if after I go, Tom is willing to unmute and ask a few of his. So my first comment is, I used to think that this was just an illness that existed with morphine, a very narrow subset. And maybe that's because morphine like hits all the classic boxes, right? It's got toxic metabolites that accumulate during acute kidney injury, and that tends to be one of the most common situations. But there was a really sort of famous study that Dr. Bruera did back in like 2018-19, where he took a look at the prevalence of opiate-induced neurotoxicity in his acute inpatient palliative care unit. And it was like 400 some patients. So it was quite a nice study. And he was able to show that every opiate they used had the potential to cause it. I mean, hydromorphone, hydrocodone, oxycodone, fentanyl, morphine, all of them had caused it in at least a few cases of his. So this is possible in just about anything. My question for you is, for some palliative care folks, maybe new to the field, they may have never seen this before. Can you give us sort of a pragmatic approach of what you would do sort of step by step if you were in hospice or in the hospital and you're rapidly escalating opiates and it's causing hyperalgesia? How would you approach it? How much do you dose reduce? Do you rotate right away? Some pearls about how we can treat this.
Well, as I say, thank you for your question. I think this is definitely not a one-size-fits-all. I think it's very important to identify the patient, their comorbidities, exactly in which situation are you on. If this is acute pain, acute and chronic, or chronic pain, how much time do you have to make adjustments? Ideally, my thought process is that if you have them on an opioid-inducing in a hyperalgesic opioid, you try to reduce the dose. If you've been escalating pretty quickly, it's easier to reduce a little bit faster. You could try a 25% reduction and then add on something that can have the other specific properties that we were talking about, possibly methadone, possibly some ketamine. So that is sort of the big picture of what you can try to do in a in an acute, quick setting where the patient does continue to need significant pain control. In a chronic pain setting, it's sometimes a little bit easier because you can see them in clinic. You can week by week wean them off the opioids in a very small fashion, maybe 10% every week or every 2 weeks or sometimes every month. And that gives you room to add on other things at the same time that can help manage that pain. So sometimes I feel that maybe the acute setting might be the hardest to work with, but definitely you have some tools that you can work to help mitigate the hyperalgesic syndrome.
Peter, the floor is yours.
Okay, wasn't sure if you wanted me to just jump in or what. Sorry about that. Thanks very much for the talk. I specifically am very interested in the literature I've read on buprenorphine for various things, use of it more in chronic pain for this particular situation as well. Would you have any recommended approach on how to start buprenorphine on a patient who is dealing with hyperalgesia? I know there are different formulations out there. The patches are quite low dose, but the films offer some more extensive dosing options. Just wondering your thoughts on how to approach and start somebody on it.
Thank you for your question. I obviously welcome anyone who has a little bit more experience than me on this, but having seen how one of my preceptor does it, it depends on the morphine, on the dosing or the OME that the patient is currently requiring. So ideally, you calculate the OMEs that the patient requires and you try to reduce that dose, whether it's 10% or whether it's 25%. And then you try to fill in that gap with the buprenorphine patch. And as you say, we have the smallest dose is 5 micrograms per hour. So that can sometimes not be enough. And we can sometimes go up to 20 with that small patch, or we can use the film, as you say, that has higher doses. The film, which is interesting, has good instructions and indications on how you can kind of make these adjustments. But I don't think that there is a specific as to which dose I would start, to be honest. I think that it all depends on what the actual requirements the patient is currently having with their current opioid. But ideally, you want to reduce that dose so that then you will add the patch to kind of fill into what the patient was already receiving, because you don't want to decrease the OME, the total OMEs.
I think, hi, this is Dr. Arshad, and Andrea and I work together, and we have recently started using buprenorphine. Again, we basis based on the patient's oral morphine equivalent dose, and there was a good lecture from AHPM that we took as a guide. For an opioid naive patient, or we're saying daily oral morphine equivalent dose of 30 or less, we usually start with 5 microgram per hour transdermal patch. As you know, it's changed every 7 days. And we continue the PRN opioid, so that if the patient is, although 5 microgram, we're talking not about milligram, but 1,000-time reduced dose in microgram, again, because of the characteristics of buprenorphine and how tightly it adheres to the opioid receptors, and a few of them. We find it more effective, but it takes time. The patch is not immediate acting. So we continue the PRN doses. And again, the maximum FDA-approved dosing is 20 mic of patch, which it kind of equates to about 80 oral morphine equivalent. And as you are going up on the doses of the oral morphine equivalent doses, sometimes it becomes difficult, because when we reach doses beyond the buccal film, and we haven't used the buccal film because obviously it's also expensive. We have used patches You guys already know this, that in FDA approval is only for 20 mic patch, whereas in Europe they're using up to 40 mic per hour buprenorphine patches. So again, understanding what your patient requirement is, and you'll be surprised that despite patients requiring high oral morphine equivalent doses, when you transition to be something like buprenorphine and the way it works, sometimes the OME requirement decreases, and these smaller doses of buprenorphine suffice for chronic pain, as we understand chronic. And that's also an idea why ketamine might fail chronic pain, because chronic pain is very different. It's not just a phenomenon of central sensitization. It also has psychopathology. It has social determinants. Therefore, ketamine can only explain for pharmacological concepts. And again, I think I'll pause here. I hope it helps.
All right, Tom, we'll let you finish up our questions.
Great presentation, Andrea. You put me into a lot of thought. The first question was prompted from the last person that was speaking. You know, in I practice in geriatrics and internal medicine, so a lot of times we prescribe medications, but the literature says combine it with behavioral health services, combine it with other components other than just prescribing. In your clinical practice or in your work, do you have any thoughts about how behavioral health should be integrated? And I would say in Illinois, it's lacking. So I'm not sure if you're practicing in Wisconsin or which state. So any thoughts about how should all of these medications connect to a behavioral component?
So yeah, Andrea, I'll let you answer that. And we're here as well. Myself and Dr. Legasky is here as well.
Oh, so I think for example, in our palliative care clinic, we usually have a holistic approach where we have spiritual support, social work and counseling, and that can also include in some parts of behavioral health, because as we know, much of the pain process and the pain syndromes have a component which is psychological as well. So I think it's always important to have this holistic approach to these patients, because it will make a difference at the end of the day. And as you say, I think some places are better at that than others. But I think every patient who's being managed, whether it's chronic pain, should have a referral to behavioral health, and they can do cognitive behavioral therapy. They can do many other things. And I know they have so many things to offer for these patients, which can also help with the process of treating them.
I have a couple of rapid questions. With the OIH, happens one time, stop the medication, goes away. To what degree can you reuse that medication? Because I get really nervous and I say, well, I'd rather not use it. But any literature or any thoughts that you have on using it a second or third time?
Yeah. So in one of these reviews that I used for my presentation, it had mentioned that they tested this and they were able to tell that a patient who will develop OIH at some point can develop it at any time, at any point in time again. So it's very easy that if you expose this patient to the opioid again, they can develop hyperalgesia again.
The other thing that I think is important is to consider why opioid-induced hyperalgesia occurred in the first place, other than increasing doses. So you would want to look, for example, at is there anything metabolic going on? For example, is the person's renal function declining? Do they have any neurologic symptoms such as myoclonus developing, increased confusion and all? And if that were the case, I would be more inclined to switch to a different opioid.
And, you know, Marty can cut me off, but I saw a map where you had an S1, S2, and I know you spoke about the core stuff, but the S1, S2 looked like it was in the cortical areas, and it looked like it was in the motor sensory. To what degree can we manipulate? Like, is it movement, like that can inhibit this pathway? Is it, listening to music, aromatherapy, like those S1, S2? Can you just elaborate a little bit about those? If you can.
I really would have to look more into it, but I actually agree with you. I think all of these things should be able to help, right? Because there are different components, and that's a very important one. So I would think that patients would benefit from all of the above, aromatherapy or any of those.
And I'm going to follow with two unfair questions. Number one is, why does ketamine work for acute pain but not chronic pain? And I had one patient in my career, I used ketamine nasal, and they got more of a mood, like an SNRI kind of effect from the ketamine nasal. But any thoughts from what you know, why isn't it as successful in chronic pain?
I wonder, this is really my thought, that maybe certain cases with chronic pain have many neuropsychiatric conditions associated with it, and we know that ketamine can be more affected in these conditions, patients who suffer from anxiety, from other things. So I'm suspecting that has the component, whereas it doesn't work as much in chronic pain, mostly because these people suffer from neuropsychiatric conditions at the same time, possibly. I am not sure.
Yeah, and it was a strange case for me. She felt better, and then she didn't want to take the medication because she was feeling better. So chronic pain, acute pain is a mystery to me. Last question. You mentioned the COMT pathways with the adrenergic component. Do Parkinson patients experience pain differently at a biochemical level?
I'm sorry?
Do Parkinson's patients experience pain differently at a biological level?
One would suspect, but I haven't read much on that data specifically, so I would probably have to get back to you on that one.
I want to, on my side, thank you for the presentation. Thank you for being able to take questions.
Thank you so much.
Those were tough questions.
Yeah. Good questions.
Good ones.
I have some homework right now.
All right, Andrea, thank you so much for your time today. We really appreciate it. And everybody have a wonderful weekend.
Thank you, everyone. Take care.
Happy holidays.
Happy holidays, everyone.